All right, welcome everyone. It is my distinct pleasure to introduce Dr. Patrick Sullivan, who is the Charles Howard Chandler Professor of Epidemiology at Emory's Rollins School of Public Health. He is a veterinarian with doctoral training in comparative and experimental medicine. Prior to joining Emory's faculty in 2008, he served at the CDC for 12 years in the Division of HIV/AIDS Prevention, including 2 years at the Epidemic Intelligence Service. He's made tremendous contributions to the fields of behavioral epidemiology and interventions for sexual and gender minority people, especially young men who have sex with men, and on data visualization to support HIV and STI prevention efforts, with over, in my brief search, 400 publications in these areas. Today, Dr. Sullivan will highlight his outstanding work on data visualization in his presentation, Measuring PrEP Uptake and PrEP Equity, How Will We Know When We've Succeeded? Dr. Sullivan, take it away.
Thank you so much, and thank you for having me. It's an honor to provide this to colleagues at UCSD and one of my favorite and most engaged topics at the moment. So I'm Patrick Sullivan. Dr. Little mentioned like a lot. I consider myself an HIV epidemiologist, but a lot of what I've been engaged around is sort of data visualization to help guide public health response. And an outgrowth of that is thinking about how we measure, just in epidemiologic terms, our progress. And I think in the HIV epidemic, because as I'll get into in more detail, there are these marked disparities in who is impacted by HIV that we need to think about in an equity framework metrics to reflect that. So I want to disclose that I get research grants and consulting fees from Gilead Sciences and Merck. And this is around some of the work for the data visualization and some of the AIDS view stuff that I'll show you later. So as you are all aware, PrEP was approved for HIV prevention in 2012 in the US. And I think we can't talk about whether we have equitable PrEP programs without acknowledging that Black and Hispanic people have higher rates of new HIV diagnoses in the US compared to white non-Hispanic people, that people in the US South have higher rates than people in other regions. And I think the guiding principle here is that health equity would dictate that when we talk about access and use of prevention programs, it needs to be proportional to the impact of the health concern in the population. And so we'll get a little bit more quantitative about that, but basically the communities that are most impacted, that are most at risk, should be the ones that are receiving a disproportionate share of our prevention efforts. So I want to organize my talk by just thinking about what tools we need to answer questions about whether we're being successful in PrEP uptake and whether we're being equitable. So and then each of these, it turns out, has been a little or a large research project, and I'll walk through some of the people who've really contributed to this pool of knowledge. So if we really want to understand how we're doing with PrEP uptake, first we need a population-based denominator. A population-based data source to understand who is receiving PrEP. And we would think of this as the numerator in an expression of PrEP coverage. We need denominators of people with PrEP indications. And so while this might seem straightforward, when we get down to trying to understand, for example, the number of men who have sex with men in the United States by state and by race, ethnicity, and by age, that actually is difficult. You can't access it directly with sort of the census data or other population sources. We need to figure out what the targets are for PrEP coverage related to our HIV prevention goals. So how much PrEP uptake do we need to get to make a certain impact in the population? And then we have to figure out how much use there actually is in key populations. And this becomes a matter of data triangulation, where we can get some things from commercial pharmacy data, but we don't always know, for example, among the men using PrEP in a commercial pharmacy data source, what proportion of them may be people who inject drugs, may be men who have sex with men. I want to focus today on equity indicator metrics. And I'll tell you my punchline up front, which is I think we should be measuring our success or lack thereof based on equity metrics and not just PrEP coverage. And finally, we need systematic ongoing data streams so we can monitor the progress of these metrics over time. So I want to start when we talk about, I'll use these questions as a framework, but I want to acknowledge our recent loss of Dawn Smith, who was such a beacon and a leading voice in this field, was a mentor to me when I was at CDC, has been a colleague for years. And you'll see as we go through some of these papers that she was either leading them or she was inspiring them. So I just want to, I'll show a number of the people who've led this work, but I especially want to call out Dawn as just the driving force in moving these discussions forward. So I want to start with a population-based data source for PrEP. And so we can use commercial pharmacy databases to understand how much of the agents for PrEP are provided. But Robertino Mera Geiler has led work to really figure out how we go from knowing that a patient was prescribed TDF-FTC to making the conclusion that that person is a person who's using PrEP. And so basically the goal here is to identify the subset of TDF-FTC users, and now obviously there's Descovy as well, that are that are using this for PrEP. And so we first start by identifying the subset that are monotherapy, and exclude other indications for monotherapy, like treatment for chronic hepatitis B infection, maybe use in a PEP combination. And so this process of first looking for monotherapy and then trying to make sure that that because of errors in in how the data were captured or other reasons, that there wasn't another indication for TDF-FTC in an HIV negative person. And to validate that algorithm, they used two approaches. One was using electronic medical records, where they applied this algorithm and then went into the EMRs and looked at the full records to try and just confirm that something that was identified as a PrEP indication was a PrEP indication. And second, did the same thing in a community-based sexual health clinic, where they ran this against the records and then went into the charts in a clinic setting. And what they found was the sensitivity of this definition was quite high, over 99%. The specificity was 87%. And the kappa statistic, for those of you that like these sort of semi-quantitative measures of agreement, was 0.76, which means like there's a certain amount of agreement that's expected as to whether an indication is for PrEP or treatment. And this definition accounted for 76% of the opportunity for improvement. And that's considered a substantial agreement. So having that, we began to develop enumerations of PrEP users, and I'll show you how we share those data sets and what we've done with them on AIDSview a little bit later. Next is figuring out the denominators of people with PrEP indicators. And so one important step of this was led by Jeremy Gray, who now is in the Division of STD Prevention at CDC, and who happily for us worked as a postdoc with us at Emory for a number of years. And basically, Jeremy used multiplier methods to estimate adults with PrEP indications by risk, race, ethnicity, and jurisdiction. And he published the first iteration of these. We continue to update them and make those data available, again, in a way that I will show you where you can access them. And John Smith also, was key in this work. They estimated at the time of the initial estimates that there were 1.3 million US adults with PrEP indications, 814,000 MSM, 258,000 people with heterosexual risk, and 73,000 people who inject drugs. You see the racial ethnic distribution there. And among the heterosexuals with indications, sort of disproportionately women, sort of a 2-to-1 ratio. Next, I want to talk about the question of targets for PrEP coverage related to related to prevention outcomes. And the question here is really, how many people need to be on PrEP to reduce HIV incidence by a third, or you could say by a half, or whatever our goal is. And the answer, like epidemiologists are frustrating people to hang out with because our answer is often, it depends. And then the question is, next question is, well, what does it depend on? And the answer is, it depends on both the risk population, who you get the PrEP to, and adherence. So modeling led in collaboration with CDC and led by Sam Jeunesse at Emory have really developed some pretty good resources for this. It suggests that we would need 40% coverage of PrEP among MSM with indications to get about a third reduction in incidence. And another way to look at that is, how many people do you need to treat with PrEP to prevent one infection? And that number needed to treat is 25. And so these benchmarks are important if we want to ask, do we have enough people on PrEP? And we want to relate that to essentially, national targets. But through 2017, which is the last time we published data on from the triangulated data sources that I'll show you next, we're falling short of that goal. I sort of mentioned that we can get from commercial pharmacy data information about, for example, how many men are on PrEP, but most often from commercial pharmacy data, we don't know of those men, how many are men who have sex with men who have sex with men and women, or men who may have other risks. And so Travis Sanchez and Maria Zlatarzinska have really come up with a data source that has been a resource to many, many researchers called the American Men's Internet Survey. And this is essentially the CDC NHBS system. Travis and I worked together at the time NHBS was launched at CDC. Travis is the Associate Director for Science in that effort. And so he's really taken that, that covers, as you know, 26 major metropolitan areas, or maybe 29 now. But the AMOS survey is a national survey that also includes important populations like less urban men who have sex with men. So this is an annual cross-sectional survey of about 10,000 MSM. And we sort of have looked at, I'm going to see if I can activate my pointer here. Not sure if I can do that. Can annotate. Let's see. All right, I'm not gonna. Can you see my my mouse on the screen?
Yes.
Yeah. Okay. So we sort of looked at a PrEP cascade of PrEP awareness, willingness to use PrEP, and ever having used PrEP from 2013 to 2017. We're sort of due to update this, but this is the last published one. But the point that I want to make is that non-Hispanic white MSM in these data had kind of comparable levels of awareness of PrEP, comparable levels of willingness, and pretty close levels of having ever used PrEP. And so we really struggled a little bit with when we did this about like what we might have done wrong and recoded things, because I think our sense is that that Black gay and bisexual men are underserved by PrEP. And our surprising conclusion here, like even considering the biases of this kind of data sources, but it's a big sample, inclusive of urban and non-urban areas, is that the prevalence of PrEP use in men was roughly equal in non-Hispanic, white, Hispanic, and Black MSM. So this turns me to what I really want to talk about today, which is how we frame the discussion about PrEP. And I want to introduce you or reintroduce you to this framework of health equality versus equity. And equality would say we sort of give the same step up to everyone, and then we've treated everyone equally. But as the left panel here shows, people come to the need for healthcare services and prevention with different needs. And so one of these people in the left panel, the person in the red shirt, actually would have been able to see this soccer game. I think this is a soccer game given what's going on in the world right now, but see the US soccer game without a step. He didn't need one. The person in the middle can just see it given the what they've been provided. And for the person on the right, the assistance that was offered wasn't of the right magnitude or sort. A health equality framework would say we want people to have equitable outcomes, even if that means everybody doesn't get the same thing. And so the right panel would depict more of an equitable outcome. And I think we often, start by thinking consciously or not about an equality framework. And so our surprise here that there was sort of equal use shouldn't be confused with the idea that there was equitable use. So but the next thing that I posed is that we needed an indicator to measure equitable uptake. And so here, Aaron Siegler, my colleague at Emory, developed this other way to think about this, which is instead of saying we want to talk about the prevalence of PrEP use in a population, Aaron proposed this metric of the PrEP to need ratio, which is just a ratio-based measure where the numerator is the number of PrEP users, which again, we now get from this commercial pharmacy data source and published on AIDSview, and the denominator is the number of new diagnoses. The idea that the uptake of PrEP should be in proportion to the need in the community. And so the intuition here is that more PrEP use is needed in groups that have higher diagnoses. And just to show you how this changes the way we might evaluate data, the top map here is the prevalence of PrEP users per 100,000 population and then put into quintiles. And so here we might see the areas of relative need as being largely in the Great Plains and the northern tier of states in the US. And these are states that do have low levels of PrEP use, but also have very low levels of HIV diagnoses relative to other parts of the country. When we look at the PrEP to need ratio, we get a completely different answer, which is that we need to be focusing in the South. And I think most of us would agree that the bottom answer is actually the right one, that we want to be figuring out where we need to do more based on PrEP to need rather than on the prevalence of PrEP use. So Aaron introduced this idea, and I think as so often happens, a simple idea, and that's not to take away from him in any way, but like the idea of developing a metric that helps us think in this way can often reshape how we think about a lot of things. And so Aaron went on to sort of try and figure out how this related to policy considerations. And just by looking at the state level, the question he asked was, what is associated with higher PNR in terms of policies? So what he found was that just PrEP prevalence, that sort of crude measure, was higher in areas that had PrEP DAP, Medicaid expansion, or both, but that the PNR, meaning more equitable PrEP use, was higher in areas. So the referent here is areas that have neither Medicaid expansion or PrEP DAP, like my home state of Georgia. And these are states that had either PrEP DAP or Medicaid expansion, had about a 25% higher rate of equitable PrEP use, and those that had both had double the rate of equitable PrEP use. So why is this helpful? I think one is that it sort of validates the idea that the PrEP to need ratio is speaking to something that is important relating to access. And two, I think it's a way to talk to policymakers about what's happening in states that have taken one or both of these steps. So I'm now going to present data that I presented at the IAS conference. It's along these lines, but building on the tools that we've talked about. The reason I went through the whole first steps of this is that we sort of boiled down to a few lessons learned here, but I want to acknowledge that the group of people who have been working on the pieces of this and putting together this story over a period of years. And then sometimes you just sort of find that a story comes together using all these tools that I think is a really, for me, was a compelling one. So we use these commercial data pharmacy resource to enumerate PrEP users by race and census region. I'll talk a little bit more about race in a moment. The race ethnicity data were only available for about 34% of PrEP users in 2021 because of the nature of the commercial data source. So we did sort of a crude assumption, which I'll talk a little bit more about, which is to assume that the racial distribution was the same within a state for PrEP users missing race data as those reported in race data. Almost certainly a not true assumption. Next, we use the PrEP to need ratio, this metric of PrEP equity, which was the number of PrEP users divided by the number of new diagnoses in the same race, sex, age-specific group. And in this analysis for 20 and 21, the PNR reflects the number of PrEP users over those newly diagnosed with HIV in 2019, because 2019 diagnoses were the most current data available at the time. And as we talked about, this PrEP to need ratio is really a reflection of the distribution of prescriptions relative to epidemic need. So this is, I think, the main new data. And I just want to point out several trends or patterns in these data. So just to orient you, each one of these quadrants is a region of the US. So we have 4 US regions. Within each quadrant, there are 3 lines. The purple line reflects the PrEP to need ratio in white residents in that region. The Hispanic PrEP to need ratio represented in the yellow line, and the Black PrEP to need ratio represented in the black line. I'm sorry, the Black PrEP to need ratio represented in the red line. And then this is replicated for each state. I want to, before we sort of look at, and because this PrEP to need ratio is a little bit challenging to understand, but I want to call us back to a number that I shared earlier, which is was the number needed to treat being 25. We need to have 25 people on PrEP in a specific group to avert 1 infection. And so this really, PrEP to need ratio begins to reflect that intuition. So for example, in the Midwest, we had 26 people on PrEP for every 1 new diagnosis. So we might think of that as at least some kind of a point to ask, how much is enough? So here's what we see in these graphs. First, the PrEP to need ratios overall and in each racial ethnic subgroup were lowest in the South compared to other parts of the country. Note also that the prevalence of PrEP-DAP programs and the prevalence of Medicaid expansion is lower in the South than in other parts of the country. The prevalence or the PrEP to need ratios were highest overall and in all racial ethnic groups in the Northeast. And then within each of the regions, the same pattern occurred where the highest PrEP to need ratio was among the white residents in that region, an intermediate level of PrEP uptake relative to need in the Hispanic residents, and the lowest PrEP to need ratio was in the Black residents, and this was true in each of the regions. And the last thing that I'll point out is that if we think about this arrow, the length of that blue arrow as being the extent of the inequity, in other words, the distance in the PrEP to need ratio between, in the Northeast, the Black and Hispanic being quite close to each other in 2016, and the PrEP to need ratio on white residents of the Northeast in that year, that is the extent of the inequity. And if we look across time, we see that the extent of the inequity is actually increasing over time. So we're not getting any better as we have more PrEP use. We're actually having more inequitable PrEP use. We can break these down and sort of consider this within a region by race. And this just shows that PrEP to need ratio that is race specific by state in the South. And this sort of depiction, and these are available for all the regions on AIDS, and I'll show you where to find them, but this sort of depiction really is just a graphical way of showing that the PrEP to need ratios across all the states, individual states are highest in the white, that the Black PrEP to need ratios are consistently the lowest and an intermediate extent for Hispanic. So these data are available numerically and graphically for every state, for every region, and for the US. And I want to just sort of wrap up this piece by saying, other than that we should be motivated by a sense of equity, and I think there's an increasing discussion about that. It's also pragmatic to try to make sure that PrEP reaches people in proportion to their need. And so I'm showing you data from William Godel, who used sort of the PrEP to need ratio as a outcome in agent-based modeling, and asked this question, so that we know that there's this sort of excess incidence in Black MSM, excess incidence rate ratio. And so what Dr. Godel asked was, if we scale up PrEP programs where the PrEP to need ratio is sort of like 1 for white MSM and 1 for Black MSM, this is specific to MSM, or 3 for white MSM and 3 for Black MSM, along this axis would essentially be equitable PrEP scale up and coverage. There would be a greater proportion of Black MSM taking PrEP to reach this PNR of 10 for both. But as long as you are on that horizontal line or falling on this side of it, which is sort of a relatively higher PNR for Black MSM, you will actually decrease the incidence rate ratio. In other words, we'll improve the disparity in Black-white diagnoses if we have equitable PrEP uptake, or if we have PrEP uptake that actually is even more weighted towards Black MSM. But when we have the opposite situation, which is quite high PrEP to need ratios among white people in a risk, or members of the population, you actually can worsen the disparity in diagnoses through PrEP programs. And so this ratio of 8 to 1, for example, would be detrimental to the disparity in new infections. And I just want to go back now and look at the kind of disparities that we're looking at, for example, in the Northeast, a 10 to 1 disparity in the PNR PrEP uptake. That number is about 8 times in the South. That number is about 9 times in the West. And when we're talking about that extent of disparity, we are up in this zone where our current PrEP programs would actually be predicted to increase the Black to white incidence rate ratio because we're not getting PrEP to the people who need it most. So there are limitations. There were substantial amounts of missing race data. We did look, and the missingness did not vary by region, but I think there are important reasons to think that the distribution of race among people who were missing race in the data set might be different. Those race data are derived from an Experian like credit file, and so the likelihood of being in that is likely related both to socioeconomic status and potentially to race. PNR is just an equity metric, so there is no real target level. I sort of mentioned the number needed to treat as one way to think about it. But our analysis doesn't really directly say what levels of PrEP use would be required to achieve incidence outcome targets, for example, but they can be used to say whether we're expanding equitably. And our calculations might be impacted by underreporting of HIV diagnoses or misclassifications of pharmacy data. And I addressed sort of the validation of those classifications of pharmacy data earlier on. There are still opportunities for us in this field that we continue to pursue with colleagues. There are some closed data systems that are excluded from PrEP estimates. That includes Kaiser, or sort of managed care organizations. Kaiser is an example, the VA, and these are potentially important sources of information. It means that our estimates of PrEP use are undercounts. PrEP denominators for women in the method developed by Don and Jeremy really only estimate PrEP indications for women proportionally to MSM indications. So if there are 10 new diagnoses in MSM for every 1 in women, the inference was that there would be that same ratio of 10-to-1 in people with PrEP indications. And I think this is as important and benchmark as their work was. It's an oversimplification because it doesn't address the heterogeneity of risk within women, socioeconomic status, access to healthcare, and differential risks for women by race. That and the issue that I just mentioned, which was misclassification of race, likely interact to increase misclassification overall. And then we have new PrEP formulations like LAI PrEP that are going to need to be integrated into monitoring PrEP monitoring methods, as are a further characterization of event-driven PrEP. So in conclusions, I'm suggesting that PrEP programs and prevention programs should be guided by PrEP equity and not by PrEP equality. We shouldn't be looking for equal use. We should be looking for equitable use. And by this measure, US prevention programs in all regions actually had decreasing PrEP equity over time. Those larger, sorry, my dog is chewing on my hand, hazards of Zoom meetings. Those progressively taller bars represented increasing gaps in PrEP equity. The US South lagged all regions in equitable PrEP use. And we need better programs to provide PrEP to communities and make sure that we reach the people at greatest risk. So how do we advance this conversation? There was a presentation at IAS 2022. I'm going to show you some AIDSview infographics, and all the data for everything that I presented are available on aidsview.org. It's dangerous to say that when I don't have the publication finalized yet, but there they are. And our hope is that if you have questions either locally or regionally or nationally, that you will access the data on AIDSview, the PrEP use data, and use them. And if we can help you to use them or clarify what they mean, you can email me, and we have a team of people who can be helpful. We definitely need better methods for addressing missing race ethnicity in these data. That's something that we're working on. And we want to use those to produce additional public use data sets so that researchers can increasingly engage with these. So I just want to show you a few screenshots of AIDSview. And this is the PrEP use data are one of the products of the AIDSview site. And everything that is displayed on our site, unless it's restricted by CDC for privacy reasons, we make available as downloadable data sets. So I've just shown you a screenshot, but I tried to scroll down. If I scroll down, the PrEP use databases go all the way back to 2008 and go all the way up to 2021 currently, I think. And you can download them. They're by state, by sex, by lots of different axes. These are just the PrEP data, but we also have all the data on HIV incidence, on PrEP to need ratios that are downloadable. In terms of other tools and resources, we have infographics and downloadables. And these, I just am showing a couple PrEP ones again, like you could scroll down and see more on the site. But the reason I point these out are that for every awareness day and for every major data launch that we have, we put out these infographic panels and we make them downloadable. And so on the next slide, I'll just show you, these are some of the, we call them data insights, but from the PrEP launch. So in 2020, Black people represented half of new HIV diagnoses in the South, but only 21% of PrEP users. This is a slide by age. This is one that talks about the sort of annual increase in PrEP use and how that was sort of lower during 2020 during the pandemic. And so these are like shareable, bite-sized pieces of information. And I would encourage you to, if you have social media channels, to just pick one of these that speaks to your region or speaks to that you find interesting, and share it on social media. I really think that for all the amazing work that's done by our colleagues, that work is
¿Estás durmiendo todavía?
that that work is so sort of only as good as the extent to which we translate it and make it accessible to policymakers, advocates who can try and move things forward. So these are some examples of infographics. I want to end by thanking, as you can see from the faces that I put up, this has been a multi-year effort that's really, and the innovations really come from all kinds of colleagues who are invested in this work and who've been leading in this work. So those are those colleagues. And I'll sort of end by encouraging you, if you have a phone, you can follow AIDSview either on Facebook or on Twitter, or this QR code will let you sign up just to get notices when we post new data, or when we're going to have webinars about new data, if you're interested in being on the AIDSview listserv. So I sort of intentionally tried to make sure that we had a solid 10 minutes for discussion before people have to head out to their next endeavors. So I'm going to end the slideshow, but really, hope if people have questions or have data needs or are wondering, how you're evaluating, the state or the, other programs that you're involved with, that we can talk about that. So I'll end there and see what questions people have.
Patrick, thank you so much. Outstanding presentation. Maybe I can just start. In the PrEP number needed to treat, 25, I'm just curious how you considered adherence in that metric, and has it changed? And then you mentioned the consideration of long-acting CAB-LA. Have you already done any work? Do you think it'll change, et cetera?
Yeah, so the question about adherence is a really good one. And basically for the number needed to treat, we sort of use a single static value. And I think one of the things that you consider clinically, I'm sure, and that we need to do better at in the models is having more nuanced data on adherence, because to my knowledge, sort of younger people may have differential adherence compared to older people, and other kinds of socioeconomic status variables also weigh on that. So I think that's just an improvement. And I want to say that we used an average from the literature, which was in the 60-ish percent adherence, but I can follow up on that.
Okay. Okay.
But I think for all these things, I think the message is that if we're assigning one value to a population, it's probably wrong for nearly everyone. Yeah. And so I think the more we think about, and I'll just put, I think, again, the people on this call will have information that's better than mine, but I know from our research studies, even with PrEP, that, when we had PrEP failures and we would debrief with people and do qualitative work, that the challenges to taking PrEP are not evenly distributed in the population. And we found in that study, which is a black-white sort of observational cohort, that people with more housing instability, for example, were more likely to come in and have these PrEP get infected while prescribed PrEP. And when we debrief, the stories were often things like, I was short on my rent and I had to leave and I forgot to take my PrEP pills with me, and then I couldn't get back into the apartment to recover my stuff or I was couch surfing and I didn't want to have a bottle of pills in my pocket because people would ask. So I just think all these, there's all this, heterogeneity within what those barriers are, and it sort of gets rolled up sometimes into socioeconomic status or race. And I think that's where the insights of clinicians, because if I have some of these stories, then I think that the people who are really prescribing PrEP probably have a lot of them. And so how do we really identify the things that are driving those inequities?
Let me open it up. Other questions from attendees?
I can ask a question. It's more of, hi, Patrick, this was incredible, and love the work, and it's really helpful for us. I've seen all, we know about the inequities in PrEP. It's gotten to a point where and I'm a clinician who prescribes PrEP pretty regularly. When I see a patient who is white, I gulp, I sigh, and I'm like, am I making things worse? It's really a weird feeling. It's almost like, and I'm serious, it happens, and I'm like, and I'm not obviously not going to not prescribe it for that person. But that is absolutely, and certainly in San Diego, it's what we see quite a bit, and then we see a healthy population of Latinx individuals as well. But I definitely get this. What are we doing? And am I making this worse? Are we making this worse? And I'm just curious. I don't know if there's an answer for that and what to do. But is that something that you hear about from other clinicians, other providers who actually feel guilty about prescribing to people who are white? Because we're making this worse, but obviously still trying to help the person in front of us.
Yeah, I mean, I definitely hear frustration. I'm not sure I hear it as guilt all the time, but I hear it as frustration and especially when you present these data, because, healthcare providers, as I said, like I'm a researcher, so I find these things in the literature and I find these things in conversation with colleagues, but I think you're really like seeing day to day, and I think there's frustration. And the question is always just like, how can we actually, improve this? And I think that part of the thought about health equity, I talked about sort of equity and equality, like in the data and what our goals are, but I think that there just have to be more resources placed, or an understanding that it actually may cost more to reach people who are more disconnected from healthcare. And I think some of these decisions, I wouldn't take too much blame, because it's not that you're not like trying to make the same opportunity available to everyone. So there's a lot of factors that are upstream to people coming into the clinic. And so I think in California, you have sort of both, pieces, right? You have Medicaid expansion, and you also have a PrEP program. So for people, like one, you can help those of us who live in places that don't advocate. And I think there's a piece of this that has to be advocacy at the national level for Medicaid expansion. I know that's probably a little unsatisfying, but I think the data suggests that would make a real difference. And then I think, we even in our research programs have we have a research program currently that is looking at PrEP choices. So I co-lead with Colleen Kelly, who is just like an amazing clinician who probably has some of the same experiences as you. And we realized just early on that we were having more sort of failures to come back, like after the screening and start PrEP in the Black compared to other participants. And so we called and talked to some of them. And what we do now is we just offer Uber rides, we offer MARTA cards, because those are real barriers to them coming back in to start their PrEP in the research study. And we may have more flexibility to do that. But we've really come pretty close to equal, re-engagement, but that sort of resource is much more needed by certain groups. And so I know you don't always have the resources to do that, but I mean, to me, the question is always why, because you talk to patients, I talk to research participants, there's no less motivation to protect oneself. It's a sort of convergence of largely socioeconomic, privacy, stigma, and just logistic challenges that make it harder to come in. The other thing that I'll point out about some of those early pieces towards PrEP, I mean, the question is how, like you only see who comes in. So there are things upstream to that. And I'm really excited to say that we just had a mobile app that CDC designated the best evidence intervention that we provided to men who have sex with men. And when they used it, it had features that were like a PrEP, PrEP eligibility, or like, is PrEP right for me? And it'd say, based on the answers you've given us, you would, you might benefit from PrEP, had PrEP locator, had PrEP navigation through chat, and that doubled the rate of PrEP uptake, and it was not different by race. So, like, I think sometimes it may also just be more frequent contacts with healthcare result in more discussions, or if the nature of those contacts is a greater proportion of preventive visits where screenings is done, there's a bigger proportion of problem-focused visits. So this idea of just giving people a tool, and you know, like you can do it for multiple health issues, but in this case, you know, PrEP eligibility, and it worked just as well for Black compared to white participants in the study. So I'm happy to share that paper. And right now we're struggling with another issue, which is we have an app that's efficacious for doubling HIV testing and PrEP. And my colleague Erin Siegler recently did a review of mobile apps and identified like 8 that meet evidence of efficacy criteria, and not one of them is available to a single like client in the United States. So we have a huge implementation gap for digital health because NIH funds up through, or CDC funds up through the efficacy trial, but no one is funding what it takes to put these things into a platform. So you as a clinician could say, here's a QR code, you can download this, get free HIV test kits, free condoms, you know, free STI test kits, and PrEP navigation. And so it just feels like a real shame that those tools exist, they're efficacious, and we have no way to disseminate them. So sorry, that was a super long answer to your question. But I do think that apps have the capacity to address some of this inequity in the pre-visit steps. Anik?
Thank you for a really informative talk. I have several questions, but I'm going to have to try to make them really fast. First, is that review of apps published yet? I think you mentioned it's on.
Yes. Yes, the review of apps is published and the app with efficacy is published. So okay. I can send those back. Maybe I'll send them back through Susan and Melvin.
Yeah, I can disseminate those.
Yep.
And then one of the questions I had was, would the ART maps look the same as the PrEP maps if we were looking at ART use or maybe viral suppression?
Yeah, so viral suppression versus ART coverage may be, you know, a little bit different, but I think that one of the problems in that is solved in that, like the denominator of people who need ARTs is the number of people living with HIV. And we often express that, I mean, CDC expresses that in their metrics as the proportion of people living with HIV on PrEP. So that number, I think, does account for the different prevalence by race, ethnicity. But I also would say that the sort of race specific coverage is often, of viral suppression for sure is often you know, still differential. But I think that that difference between prescribed PrEP and virally suppressed hits at a lot of the same issues that we just talked about for PrEP, which is, you know, competing needs, transportation, and stigma. Again, we had a parallel, I talked about a study of PrEP use in Black and white MSM. We had a parallel study of viral suppression in Black and white MSM living with HIV, and got a lot of the same kinds of stories just about, you know, concern about having a pill bottle, you know, instability in housing, et cetera. So I think those are shared issues.
And in terms of geographical, I mean, I was kind of wondering, like, would the states in red, would they remain the states in red for, I guess I'm trying to see whether it's kind of like a general problem of access to HIV services, or whether PrEP is kind of its own thing and kind of different strategies.
My inner epidemiologist is excited about this question because it's so answerable. I will say that I will just try and pull up on AIDSview a couple state level maps of viral suppression levels, so we can compare those to the maps that I showed, and the PrEP coverage levels. My thought is that we're going to find that there is a correlation, and the South is more impacted, but I think again that probably relates to things like Medicaid expansion, for example. Although there are obviously many routes for people to get HIV care supported, Medicaid as a way to be engaged in healthcare, like to have a more of a chance for like screening and linkage and so on. So I think some of the same underlying factors, which is distribution by race, ethnicity, Medicaid expansion, and wraparound support programs that make it easier for people to get care, I'll bet that the same overall pattern exists. Is a great question. And I'll just send back a couple screenshots on a page so you can satisfy your data.
And then, can I ask one more? Am I allowed?
Yeah.
You're
so the
allowed.
last one was regarding you described the pharmacy data quite well, but we've been struggling a lot to get data on medications for opioid use disorder. And I was wondering whether it would be the same, like what was the main database that was used, and did it cost hundreds of thousands? Because we're basically trying to get, we'd like to do something very similar to what you're doing with PrEP with MOUD. Of course, it's much harder to get a denominator for the number of people who have opioid use disorder, but it'd be amazing to show disparities. And one of the postdocs in the division is trying to do that work, Tom Patton. But basically getting the data is impossible, and we just got a quote of over $100,000 to get the data. So
it's expensive. It's expensive to get it. I do think let's and if you want to just like connect with me offline, I have two things to talk about. One is like I think we have some of the skills now, and we have a companion website called HepView that's really like very interested in these questions. And the other thing I'll mention is that I hope we'll do it again this year. Last year, we had an AIDS-U Fellows program where we gave fellowships to, I think it was earlier career last year. You know, I opened it up, but basically it's just would support the cost of buying some data or some time, you know, to answer a question with the data resources that we have. And so if we have another cycle of AIDS-U Fellows, this would be a really great topic for someone to sort of explore. And I'll just say, like, let's talk more, because there are some ways to get data more reasonably. It just takes a while, and we've been relationship building around PrEP. But yes, hundreds of thousands of dollars is not out of the
No, that was not within the ballpark that we had expected. Thank you for those answers.
My colleague Heather Bradley leads a lot of this work for our HepView project, and she's just also a great colleague. So I'd like to introduce you to her around that. So send me an email and I'll make some connections.
Great. Thank you so much.
Yep.
Other questions?
Thank you so much for bringing questions forward. I sometimes I'm tempted to pack in 50 minutes of slides because I think like people, especially at 8 in the morning, won't have questions, but I went short today in the hope that we'd have this kind of conversation. So thank you for the questions, and
sure. And because we have one more minute, I'm going to ask one more.
Okay.
You know, your comment about you know, it's going to cost more. I come up against this question a lot in low barrier care, and we live in the world of NIH dollars, and I don't think they yet recognize this disparity in cost. And so that raised the question. I did a quick search. I should know this, but I don't. Have there been comparative studies of cost efficacy or effectiveness with an equity lens by race, ethnicity in PrEP? I see them in other countries. I don't see them in the US.
I don't, not to my knowledge, but I'll bet that the data are available to do that. So
yeah. Because I think that's something that, unfortunately, given how much money drives so much in this country in healthcare, I think we need some of those studies, because, you know, when you put in budgets for some of these things, there is still this idea that, you know, PrEP care for one is equal to PrEP care for another, and same with ART, and it's just not.
One of my favorite like philosophies is that ideas are like, you know, like dandelions. If you wave them around, you come back the next day, there'll be 20 more. But I think I'll just share like my response to that is, I think a proposal to NIH that actually says if we want to get PrEP with equitable outcomes, to do a costing study of what it costs to get comparable levels of engagement and protection across several dimensions. Is it the same for men and women? Is it the same by race? Is it the same by age? To actually develop an empiric database for that. So by offering these things like Uber rides, and when we started offering Uber rides, people said like, everybody's just going to want an Uber ride. And you know what, like people who have their own transportation don't ask for an Uber ride just because they can.
Yeah.
And so like, if you just say like to everybody in a clinic, these are the resources that we have, then it would help you to plan or to do programmatic budgets to say like, given the mix of clients that we have, these are the costs that we think will accrue and have a scientific basis for that. So if you're interested, like I think that would be a winner of an idea, and it would be interesting to do it in multiple places where the cost structure.
I'll call you.
Patrick, just to that with the rides, I mean, this literally just came up for one of our PrEP patients who, you know, for all intents and purposes has the exact same needs as someone living with HIV. And one of the big issues is transportation. And we were like, oh, well, we now have a policy. We can get you 5 rides a year back and forth with Lyft. Well, it turns out that money is from Ryan White funds, and he can't access them. And so we don't have the equivalent for what he needs. And he's someone we were trying to put on Vivitrol as well. So he needs to come monthly, and we don't have a great we don't have the same pots of money for people taking PrEP, and that's become a really big issue in clinics where you're trying to meld things. So that's a whole, and that's outside of the research arena, but something that's come up and maybe researchers can think about.
Yeah, I mean, having essentially a cost effectiveness, you know, analysis of like making these other investments.
Right. Well, and I think we could talk about this for hours. We've shown that it's cost effective because of the financial return for the medications. It's just, where does that money go? And no one considers it to be ours.
I mean, the problem is that the people who pay don't realize the benefits of, you know, the cost. So that's Sweden, you know, like if all those costs and expenses accrue to like the same people, then it's an easier argument to make.
Right.
Yeah.
I'm so grateful for the chance to meet with you this morning, and so appreciative of the questions and the work that you do. And I hope this will lead to some, you know, follow-up discussions or work, but just mainly thank you for the opportunity and to talk, especially when you guys are still on your first cup of coffee. So
thank you so much. Great presentation and really interesting discussion. And as I said to anybody who's still on, I will forward any references that Patrick shares to the team. All right. Have a great day, everybody.
Thank
you so much.
Thank you.
bye.